All right, so really thank you to Ben Coons. Like, this was your baby, your initiative is the reason why we're here. I think it's been a great meeting, so thanks for spearheading this. Disclosures are on the app. I've got two sort of focused objectives. Really, the first is to describe indications or common indications to consider femoral osteotomy in the context of dysplasia, and then just get into some of the technical aspects. Indications are listed here. This is not an exhaustive list, but these are three of the most common ones. Femoral osteotomy without PAO, which I think is rare. If somebody has a very, very mild acetabular deformity, but their femoral deformity is severe, they have lots of anatorsion, for example, I think that's an indication. Some of the Perthes-like deformities that John talked on earlier, with an excessively high greater trochanter is an indication. But really, I think most commonly, in the focus of the next 15 minutes is after or during PAO surgery for residual instability, congruency, or impingement reasons. So this first case, I realized after I assembled all these slides that the first three cases are all 32-year-old females, and it's an accurate thing, it's just coincidental. But I think this is the gray area for many of the patients that have some early arthrosis. So I think I'm hoping it generates some controversy. This woman had pain for 7 years, typical symptomatology. She exhausted and failed conservative management, nothing out of the ordinary in the rest of her medical history. Her exam demonstrated some hypermobility. She had tons of internal rotation, both prone and flexed. And then the other provocative exams are listed there. She did have some mild weakness, and her gait was normal. So these are her AP pelvis and false profile radiographs. Numbers are listed here. She falls right at the junction of mild to moderate dysplasia. Sort of zoomed in views. Her torsion is measuring 49 degrees. And you can see if you look at the images on the right side, she does have some subcondylar cystic changes. And Cece, you were mentioning earlier that, I mean, we all know that's a marker of potentially early failure. So I think it opens the conversation for some patients in the 30s. I think a discussion of hip replacements and the pros and cons of that option, I think, is warranted when you see cystic changes. But for many patients, I think they can still have a good result as long as you're as long as they're able to understand the nuance of both surgical options. This is our MRI. There's a coronal image at the top left. And then the sagittals are moving from lateral to medial. You can see a labral tear, a paralabral cyst, and redemonstration of the subcondylar cyst. So she's 32, she's hypermobile, she has moderate dysplasia, labral tear, cysts. The cartilage on the MRI looked like it was in good shape. I know it's not an actual number of tonus 1.5, but I feel like there's a lot of these patients that don't look as bad as a tonus 2. And you know, she's got 49 degrees of anatorsion. Cece, is this somebody that you would consider preservation on? Quick show of hands, anybody that would not offer it and push for total hip instead? What are you thinking, Ben Coons, about her plan? This might be one where you consider it. Okay. It was neutral. So she underwent the stage protocol that you just heard about from Dr. No. He did an arthroscopic labral repair, an osteoplasty of the femur, and a capsular plication. And then about a week later, she underwent PAO, and I did an intertrochanteric retroverting osteotomy that was roughly 30 degrees. And this is her 4-year post-op set of x-rays. She does have very mild symptoms with exercise, but overall she's quite happy with her pain and her function with normal everyday activities. It's been 4 years. This isn't long-term follow-up, but I think, I think for her, at least at this point, it was the right option. 4 years ago. I, I, that's that's my. I should have pulled up his pictures or report, but if you remember, I'll be impressed. So the reasons that Dr. Mayo mentioned. So if I'm taking somebody with high anatorsion and retroverting them, typically interchoke. Um, Subchoke enteric, conversely, if I have somebody that's retroverted to avoid overtensioning the iliopsoas, is typically, so up until 2 years ago, it was one or the other. It was interchoke or subchoke for those reasons, the vast majority being retroverting osteotomies, so an interchoke location. And just recently, I've begun to sort of choose other locations, and I'll show you a case where I've done that. Second case is also a 32-year-old female. She is a physical therapist, no past medical history. She's got bilateral hip pain, it's been going on for over 5 years. We're gonna focus on her left side, but 2 years ago I did a PAO, she loved it, she came back in saying, I had a failed scope on my left side, I want you to do the same thing. Her gait examination is normal. She's also hypermobile with a Baton index of 6. She has some tenderness globally around her hip girdle. Range of motion is down here at the bottom right. So she has relatively limited internal rotation, so 10 degrees well flexed. These are radiographs. There's contrast still because right before coming up for x-rays and seeing me in the office, we did an MR arthrogram, which I generally avoid, but in the context of a previous arthroscopy, I generally get contrast because we don't have access to a 3T scanner. Her measurements are listed at the bottom. She has femoral retrotorsion, 2.6. I think that's sort of borne out in her range of motion examination. She also has some very mild cystic changes. She has a recurrent labral tear. I don't see, concerns about the cartilage integrity, any evidence of edema or advanced arthrosis. So what about this one? So she has 3 degrees of femoral retrotorsion. She has mild acetabular dysplasia. Would somebody take a stand and say, socket side only, both femur only? Revise the scope to the femur. It's a PAO, derotational osteotomy revision scope. Any other ideas? So she wanted the same thing done. I was probably falsely optimistic. I should have told her that her anatomy is different on the left side than it is on the right, and push right away in the office for doing a femoral osteotomy, just as you said out of the gate. When I did the correction, you can see it there on the left. This is, I think, a 1 or 2 year post-op x-ray. But after the correction, she's got 5 degrees of internal rotation. And that was not something that we had completely borne out in the office. So essentially before she left the hospital, I had the conversation with her that if you want the best possible outcome, I'd say in a week, so you have one recovery rather than waiting for this to fail, we should do an anaverting osteotomy, and with subchoke enteric, just as you were asking about, Ben. There isn't much literature to guide us on the osteotomy locations. Dr. Matto, you raised some good points. I don't think the answer's there yet. The reasons that Dr. Mayo explained make sense to me, to choose interchoke enteric or subchoke enteric. And this is the only real paper from you guys at WashU that had any really mention of, trying to decide between one and the other. When they simulated, so these are all patients with dysplasia. They had abnormal torsional anatomy, if I read the paper correctly, both retroversion or retrotorsion and anatorsion. And the joint reactive forces, if you chose intertrochanteric or simulated intertrochanteric osteotomy versus subtrochanteric, didn't change. Third case is also a 32-year-old female who's a nurse. She has a past medical history of anxiety and depression. She has had hip pain for over a year. It's diffuse in nature. On gait examination, she does have an internal foot progression angle of roughly 5 degrees on both sides. She's not ligamentously lax. Provocative tests and strength exam is listed there. And really, I think the most striking thing is what's shown in green is that she has tons of internal rotation. These are plain film radiographs, center edge angle of 4, tonus angle 25, anterior center edge angle of 6. So she falls in the severe dysplasia category, and 51 degrees of anatorsion. This is her MR. Some cuts from her MR, I should say. How about her? PAO and femoral osteotomy, I'm guessing, is what most people are planning for. And I did do that, but instead of doing intertrochanteric or subtrochanteric in location, I've done this in a handful of patients, and it's a sort of distal diaphyseal location. This is a concept that was introduced to me by Joe Schwab. And one of the frustrations that I have, and if other people have a more secure or more precise way to guide the correction, I'd be interested to hear it. But I think essentially these are our options. So you can use some sort of reference pin or drill and have somebody stand at the foot of the table with a goniometer. And I feel like this is sort of like measuring with a micrometer and cutting with an axe. I think we can get close, but it's not as precise as I think we want it to be. Patient-specific guides are available. I have no experience with them. The arc length method, which is what Joe Schwab has explained, is what I'm going to show next. And I'm unaware of any navigation technology used for it. I think there's a role for it, but at present I don't think exists. So these are the slides that Joe gave me when we were talking about this, and he made it very, very simple, just because I think he thinks I'm slow, so he made it really dumbed down. The tubes, the femur, and this is, admittedly based on the assumption, or obviously based on the assumption, that the trigonometry that he's using to come up with the arc length is predicated on the femur being a cylinder, which it's not. It's close to it at that location, but really it's a subvastus exposure along the distal diaphysis. They mark the location of the osteotomy. The plate goes on first, 2 holes are placed, or 2 screws are placed, and then a line is marked on the femur, and a second line is marked on the femur. So the distance between those two things is dependent on the diameter of the bone and the intended correction goal. So you can measure the diameter either with a drill and a depth gauge or on the CT scan, on the SCOUT AP images. You can make a few different measurements to anticipate what the diameter is going to be. The plate comes off, the bone is cut, and then the fragment is rotated depending on which direction you want the correction to go. So this is an anteverting correction. The distal segment is rotated externally relative to the proximal segment, and then the plate's reapplied. Compression is done either by using eccentric screws or, in the cases that I've done, use the tensioning device. This last one is an 18-year-old male. He lives in the country. He's still in high school. He used to play football. He's unable to at this point. He's working on his family farm. That's his long-term goal. He's really struggling with ADLs at this point. He's a big kid, and his range of motion is terrible. So he's got 20 degrees in the pure sagittal plane. He has obligatory external rotation after that, which is typical after a slip. He's got a pretty bad gait, and provocative testing, including positive Faber and Fader, amongst others. So these are his plain film radiographs. He's had a slip pinned in situ. He has severe dysplasia, or approaching severe dysplasia. He's got some sclerosis and cysts already at the age of 18. His SCFE was pinned about 9 years ago. He has 8 degrees, as best I can assess, because the proximal femur is clearly abnormal in shape. And he's got some cysts, and these are a little bit larger than the previous one. So MR was marginally helpful. You can see the cyst if you squint at the very top left image. You can see his capsule is really quite thick. And that's the information we have. So at 18 years old, he has more arthrosis than I think, any of us like, but does that preclude preservation? Would somebody push at this point for total hip in an 18-year-old?
Looking at that CT scan, I was thinking more total hip after talking about it.
He doesn't want it. Doesn't want it. He understands. He's sophisticated enough to understand the situation. What kind of surgical plan are you thinking of?
So I would do a scope PAO, try to recontour that metaphyseal bump as much as I can, and then do a derotational osteotomy.
The comment was scope PAO and then do a derotational osteotomy. John, what do you think? Is this foolish?
It's a lot. It's a lot in this zip that's on its way out. I don't know if you had his motion up there. What was his motion?
Terrible. He had obligatory external rotation with flexion beyond 20.
Yeah, I suspect I might try to keep the zip one in. Probably do a dislocation, surgical dislocation, and focus more on the impingement and instability of the hip. Even though he has acetabular dysplasia, in a way, it's like some of the early zips that have significant acetabular dysplasia, but the hip is unstable.
Mm-hmm.
Dislocation and examine it. So I'm concerned about the health of the joint. I'm concerned about worsening impingement with PAO, and I'm concerned about doing too much surgery on him. So maybe just keeping it simple, address the femur, address the impingement, and see if that doesn't go on for a while. And let him and the family know this hip is headed for trouble.
Yeah, and for sure. They're fully aware of that. They understand. Brett, what do you think?
If he was 14 or 15, I think it would be an easier decision. I would go more with what John said, probably with his slip angle.
Okay. So he's currently 2 years post-op. I did end up doing a PAO, did an open arthrotomy, fixed the labrum, and did a massive cam osteoplasty. This was the first distal femoral osteotomy that I think I did rather than intertrochanteric or subtrochanteric. But thus far, he's back. He's actually playing football against my advice, but he feels great at this point, at least at 2 years. So in summary, this is a massive topic. I just wanted to show some cases where I think femoral osteotomy is indicated. It can be done in isolation occasionally in the setting of dysplasia. It's more often concomitant or staged. Ideally, if you think the femur is going to be an important part to a good long-term outcome, as Brett has mentioned, I think offer it or recommend it right up front. If the situation arises where you're unhappy with like the rotation at the post-correction after a PAO, I think the case I showed is a good example of when to offer a femoral osteotomy. And then if they have a bad long-term result, then I think it's occasionally something that we consider and remeasure their torsion and see if there is a delayed femoral osteotomy that can be offered.